Good afternoon, everyone, and welcome to today's webinar, Million Hearts and Sodium, Making Sense of the Science and Translation to Practice. I'm Katie Protestio, and it's my pleasure to serve as moderator for today's webinar. I'm the Analyst for Health Promotion and Disease Prevention at the Association of State and Territorial Health Officials, ASTHO. Today's webinar is presented by ASTHO, the American Heart Association, and the National Association of County and City Health Officials, NACCHO, all members of CDC Million Hearts collaboration. Million Hearts is a national initiative to prevent 1 million heart attacks and strokes in the United States by 2017. It was launched by the U.S. Department of Health and Human Services in September 2011 and aligns existing efforts and creates new programs to improve health across communities and help Americans live longer, more productive lives. The CDC and Centers for Medicare and Medicaid Services, CMS, serve as co-leaders of the Million Hearts within HHS. They work alongside federal, state, and local entities and private sector organizations to make an impact against cardiovascular disease. Million Hearts seeks participation from organizations interested in targeting improvements in clinical preventive practice or community prevention. You can do this by implementing programs, projects, or initiatives in one of two areas. The first is improving care for people who do need treatment by encouraging a targeted focus on the ABCSs, which stands for aspirin for people at risk, blood pressure control, cholesterol management, and smoking cessation. These address the major risk factors for cardiovascular disease. The second is to empower Americans to make healthy choices to help reduce the number of people who need medical treatment like blood pressure, cholesterol medications, and help prevent heart attacks and strokes. Lowering sodium intake is a key component to a heart-healthy lifestyle, and therefore population sodium reduction strategies are a priority for the Million Hearts Initiative. On today's webinar, our speakers will present the public health rationale for reducing population sodium intake and share successful strategies at the state and local level for implementing national sodium recommendations. We're here today to learn from others' experiences so we can translate sodium reduction strategies into practice and share best practices and collaborative efforts. I won't read through all the objectives on the slide, but we do hope that you will have at least one takeaway from each of the speakers' presentations today. The slide on your screen now shows today's agenda. We'll begin with a discussion of the science and then conclude with the state and local initiatives, followed by a Q&A section. I will briefly introduce each speaker and presentation as we proceed throughout the webinar. All of the phone lines for participants have been muted. If you do have a question for one of our speakers, please type it into the chat box on your screen at any time during the webinar, and we'll address these questions during the Q&A session after today's presentation. It is now my pleasure to introduce you to our first speaker, Ann Callahan. Emily is in her third year as the National Program Lead for the American Heart Association's Sodium Reduction Initiative. In this role, she manages the AHA Sodium Reduction Strategy, which includes managing strategic and tactical implementation related to nutrition policy and advocacy issues, consumer education and engagement campaigns, and scientific research translation and dissemination at the national, state, and community levels. As part of AHA's Healthy Living staff team, she also works on a variety of the association's other healthy living nutrition projects. Prior to joining AHA, Emily was a program officer at the Food and Nutrition Board of the Institute of Medicine in Washington, D.C., where she worked on reports and publications focused on obesity prevention and strategies to reduce sodium intake. Emily also spent 6 years providing nutrition counseling to adult patients at a free county health clinic. She has an MPH in nutrition from the University of North Carolina at Chapel Hill and is a registered dietitian. Emily, I will now turn it over to you.
Thank you, Katie, and thank you so much for the invitation to speak today. The two objectives that my presentation will speak to are about the nationally recommended sodium guidelines and to discuss why some recent research on sodium and health has produced inconsistent results. So the outline for my presentation will cover that and a little bit extra, and these are the 4 areas that I'll cover to round things out. And the first one is the current recommendations for sodium intake. So I'm not going to read through this slide in detail, but I tried to list some of the major guidelines in the U.S. And most folks are probably familiar with the latest edition of the Dietary Guidelines for Americans, and that was in 2010. So there is a new edition that is expected to come out by the end of this year. But in 2010, the goal was to get to under 2,300 milligrams for the general population and to an even lower level for special populations that are listed on this slide. And those are groups that tend to be more sensitive to the blood pressure raising effects of sodium. So I think a lot of folks in public health are anxious to see where the 2015 edition of the Dietary Guidelines will net out. And we're at the point where we have the science report from the Dietary Guidelines Advisory Committee, and that committee has recommended that we maintain the limit of less than 2,300 a day, or whatever is age appropriate according to the DRIs, and those are from the Institute of Medicine. So the thing to note there is that for children, the limit is a little bit lower. It ranges from 1,500 to 2,200, depending on age. But for the general adult population, it would be less than 2,300. There is a note in the advisory committee report that folks with prehypertension or hypertension should follow the American Heart Association and American College of Cardiology's guidelines, which are at the bottom of this slide. The Healthy People 2020 is also out of the federal government, and that follows along with the guidelines. And the Institute of Medicine did a report in 2010 on strategies to reduce sodium in the U.S., and that really put a big focus on the need to lower sodium in the food supply. And the AHA guidelines came out about a year to 2 years ago, and those are really focused on people who would benefit from blood pressure lowering. So that would include people with hypertension, which is about a third of American adults, and people with prehypertension, which is about another third. So you're looking at a majority of the population there. And those numbers are to aim for about 2,400 milligrams a day, or even better, to 1,500 to reduce blood pressure even more. And another guideline, just for reference, is the World Health Organization, and that's at about 2,000 milligrams. So, there's a slight difference in these, but I think the one thing that they all have in common is that they're all at least 1,000 milligrams lower than where Americans currently are. And the average American sodium intake is bordering on 3,500 milligrams a day. So I think that it's more important that we really educate consumers that they just need to reduce from what they're eating, and they don't need to be, necessarily too concerned about what is the ideal target intake. I can guarantee you it's probably much lower than where they are right now. So I think it is important for the science community to have that discussion about what is the ideal lower intake level, and that might differ for different populations. But I think that we should not be stalled on making any progress just because there is some discussion about the current lower level, again, because any of the recommendations that have been thrown out are so much lower than where we are now. We have a lot of progress to make in the meantime. So I wanted to talk a little bit about where we are as a nation now and what foods our sodium is coming from. And this chart shows the breakdown of sodium intake for age groups. So you can see, looking at the dotted line, which represents 1,500, and the red lines, which represent the upper level for that age and sex group, that pretty much all age levels are well in excess of what's recommended. Again, we're at an average of about 3,500 milligrams a day. For women, it's lower, and that's because women tend to have lower calorie intake, and sodium intake is correlated with calorie intake. This is a graphic that's probably familiar to most folks on this call. The main point here is that most of the sodium in our food is not added through the salt shaker. So I think that's an important point, and something I hear a lot from the patients I counsel is that they say, well, I don't salt my food and I don't really eat salty foods, so I'm probably not getting too much sodium. But the truth is that most of the sodium in our diets is coming in from packaged foods and restaurant foods, and some of those don't even taste salty. So this slide shows the top 10 food sources of sodium in our diet. And you can see the first one is breads and rolls, which most people wouldn't think of as a high salt food. And it's not necessarily that that food is high in sodium, but it's fairly moderate, but people eat a lot of it throughout the day. They might have toast at breakfast, a sandwich at lunch, and a roll at dinner. So the sodium from the bread group really adds up. So you can see that there isn't necessarily one food group that's contributing a huge amount of the sodium. It's really spread throughout the food supply, and that's what one of the challenges is of reducing sodium. It's really dispersed so widely across the food supply. And at the right side here, I put in an infographic that the American Heart Association produced to help raise people's awareness of what those top sources are. And we're not telling people that they can't eat these foods. We're just telling them that they should really have a heightened awareness and make sure they're comparing the nutrition facts labels with these foods and choosing healthier choices. So I wanted to add this slide here about modeling because I thought it was a good visual representation of what it would really take to get the U.S. population to the levels that we're recommending in the dietary guidelines. And again, that would be the 2,300 milligrams a day. And the AHA commissioned this modeling work based on the National Health and Nutrition Examination Survey data. And we concluded that it would take at least a 25% reduction across sodium in the whole food supply to get Americans closer to that average of 2,300 milligrams a day. So, it seems like 25% is doable. That's something the food industry has been able to cut sodium by that much in certain foods. I think additional reductions could be more difficult, but there's a lot of new technology and different ingredient solutions these days, and I think there's certainly room for more progress. So I think this slide is really interesting in showing what it would take to get the population averages to recommended levels. So now on to interpreting some of the science on sodium and health. And a lot of the information in the next couple slides is taken from a commentary that I co-authored under my maiden name of Miller with several scientists that work with the American Heart Association. And I have the citation at the bottom of the slide if you'd like to read the whole commentary. So you might have heard reports in the news of some studies that have suggested that sodium intakes in the range that's recommended may actually increase the risk of bad health outcomes, especially in certain populations like folks with high blood pressure or folks with kidney disease. So naturally, this has led to some confusion about the recommended levels, and it's made some people wonder, do we need to reduce at all? Does it still matter? So I pulled a few headlines from an internet search, and as you can see, it's a little bit of scientific ping pong where, low salt diets are bad and then they're good. And, I think it's not surprising that we see these different media headlines because the media wants to report on anything that's edgy, that's different, that's not the status quo, and it's going to get a lot more eyeballs and a lot more clicks than a boring same old headline about we need to reduce salt. We've been hearing that for a long time, and the minute something kind of controversial comes up, the media really gloms onto it and I think often blows it out of proportion and overstates things beyond what the actual research has shown. So to make sense of it all, I think it's really important to note that it can be hard to interpret the results of some of these studies on sodium and health because it really depends on the types of data that are collected or not collected and the statistical analytic approach. And this does get sort of into the weeds of research methods here, and I'm going to try not to get too nerdy into that methodology stuff with this group. But an example is that a recent large study found that people who ate less than 3,000 milligrams a day or more than 6,000 milligrams had they had a greater risk of death which was surprising because we're recommending that people eat less than 3,000, but this study said actually that might be bad for them. Well, the way they measured sodium was by taking one urine sample and using that. So on the other hand, another study, they took sodium intake by multiple collections of 24-hour urines, and they showed an opposite result, was that we would reduce heart disease risk if we're eating less than 3,000 milligrams of sodium a day. So you can see that the measure they used led to the different results. So I think the really key point here is that the inconsistent results can be a result of the method's issues. And some of these studies are using data that wasn't specifically designed to test the relationship between sodium and health. So when it's coming up with conclusions about that, you have to sort of wonder, was that really the best way to get to that answer? So some of the key issues, like I said, include unreliable measures of sodium. So in general, a single spot urine is not believed to be an ideal way to measure sodium intake. Just to be blunt, would you ask someone to pee in a cup one time and measure their sodium and then assume that that's kind of a consistent amount they're going to be eating over the next 10 years and then use that to produce their risk of death? Well, no, ideally you would really want to take multiple measures of a whole day's worth of urine, because that is a key biomarker for sodium, and you would want to use that. But of course, that places a lot greater burden on the researcher, so shortcut methods are often used. Another issue is that sometimes the study population includes patients who have pre-existing disease. So they might be eating less food because they're not feeling well. They might have low sodium intakes coming in, but then they end up being the ones that die the soonest. And then the study says, well, the people who ate less sodium had worse outcomes, but the reason they had worse outcomes wasn't because they ate less sodium. They were eating less sodium because of their pre-existing problem. So you can see it gets complex, but the belief is that does explain some of the issues. So in general, the observational studies that follow people over a long period of time, they tend to be less useful, according to some scientists, than clinical trials that give people certain amounts of sodium and they have very well controlled sodium diets, and then they're very carefully measured. Those studies are what's believed to be better for giving us the evidence that we need to guide policy. So the American Heart Association's review of all of these studies with the different ways they've been conducted has concluded that, yes, we do still need to reduce sodium, and it is still a public health concern. So just some summary points are that I think it's really important for health and nutrition professionals to consider that we make recommendations after we weigh all of the evidence. And some of the studies have better designs than others. Some have conflicting results. But you have to consider things like how a study is designed, what population it was conducted in, the methodology choices they made, and how it fits in with the So even if it doesn't agree with everything else, that doesn't necessarily mean it's wrong. And I think certainly science evolves and we change recommendations when we have better methods of measuring things and we get more information. And in general, there's a lot of debate in the science world. But I think overall that really advances truth in the long run. So, this isn't just an issue for sodium. There's been some controversy around saturated fat, and I think this is the same lens that needs to be used when we as health professionals see a conflicting headline or something that's kind of different than what a lot of the authoritative guidance has been. We just have to have a really critical eye to examine that and decide how much stock we want to place in it. So the next two slides are just simply some resources for you all. They have links to some of the AHA's responses to some of the controversial research, and these are our science papers. And I'm a little over my time, so the last chunk of my slides is just some resources that the AHA has provided, mostly for consumers. We have a consumer website here with a lot of great information that you can explore. We have a funny 1-minute video. Anyone has just a minute that they can use to watch this video where we have the salt man sneaking up on people in their food where they least expect it. We also have a great selection of infographics, including some in Spanish, and we have some publications for consumers with recipes, which people are always looking for recipes that they can use. And with that, thank you very much. I look forward to taking your questions at the end.
Thank you so much, Emily, for your comments. We really appreciate you sharing your interpretation of the science as well as an overview of the national sodium recommendations. As a reminder for participants, if you do have a question for any of our speakers, please type it into the chat box on your screen, and we will address all the questions during the Q&A following the presentation. I will now welcome our next speaker, Holly Richards. Holly is the Cardiovascular Health Coordinator for the Maine CDC Cardiovascular Health Program. She works in Domain 3 and 4 of the CDC 1305 grant, along with managing the Sodium in Communities Reduction Grant, overseeing the work occurring in 2 local health departments, the Bangor Region Public Health and Portland Public Health. This work is funded by CDC's Sodium Reduction in Communities Grant, which was awarded to them in 2014. Holly began her career in 2001 as a community health educator for Reddington Fairview General Hospital in Somerset County, Maine. She joined the Maine CDC, Maine's Public Health Department, in 2004 as a public health educator for the Maine Comprehensive Cancer Control Program. In 2008, Holly was promoted to Cardiovascular Health Coordinator. Holly is a native of Maine, and she holds a Master's in Public Health from the University of New England. She is also CHES certified. Holly, I'll now hand it over to you.
Thank you, Katie. Can everyone hear me?
Yes.
Okay, so I am going to first off apologize. I have a terrible cold, so if I start hacking or something, I'm just going to apologize, but there was nothing I could do to control that. So welcome. Thank you for the invitation to be part of this webinar. And as Katie mentioned, we are a recipient of the Sodium Reduction in Communities grant that Maine received in 2014. 70% of our funds go to 2 local health departments. In Maine, we only have 2, so they go to Bangor Regional Public Health and Portland Public Health. They're in 2 of our counties, Penobscot and Cumberland County. And the areas that we are working on, we are working in 2 venues, one in health systems, and the 2 health systems in Cumberland County we are working with Maine Health, and in Penobscot County we're working with Eastern Maine Health System. And in those counties in Cumberland, there's actually 12 hospitals, and so over our 2-year grant period we are committing to work with 5 out of those 12 hospitals on sodium reduction, and in Eastern Maine there's 8, and we're going to be working with 2 out of the 8. The other venue we are working with is Good Shepherd Food Bank, and so the venue is actually agencies purchasing and providing food to congregate populations. Good Shepherd Food Bank is the distribution center for the 600 food pantries we have here in Maine, and we will be working more intensely with 8 out of 44 of the food pantries in Cumberland County and 8 out of 37 in Penobscot County. Oops. So here is a map of Maine, and I've put an arrow to Penobscot and Cumberland just so you could get a visual of where the 2 counties that we're actually working in. So some of the major partners, obviously the State Health Department, the Maine Cardiovascular Health Program. And in Bangor and Portland have similar partners. Eastern Maine Health System, the 2 hospitals they're working with currently this year is Eastern Maine Medical Center and Acadia Hospital. And in Portland, Maine Health, the health system, the 2 hospitals are Maine Medical Center and Spring Harbor. Both of them are working with Good Shepherd Food Bank, Food Pantries, United Way, Hannaford, which I'll get to a little bit more, and then other businesses that donate food. So the strategies that the health system and congregate populations are working on are availability, accessibility, increased purchase selection, and reduced sodium. And I won't go into details, but what I will say about the availability, the first bullet, the entities adopting comprehensive nutrition standards, Eastern Maine Health System is not working on that, and I will talk a little bit more. Maine Health and Good Shepherd Food Bank have other initiatives that started in 2012 and 2013 that have rolled into our sodium grant, so they had a little bit more legwork already done, and Eastern Maine's just not there yet. So with Nutritional Guidelines, Maine Health has adopted their guidelines through Partnership for a Healthier America, a Hospital Healthier Food Initiative, and the Hospital Healthy Food Initiative is part of the National Partnership for a Healthy America, which works with business sectors on the national obesity crisis, and Maine Health signed on to this initiative to be recognized on a national stage for many healthy food and beverage initiatives they had already begun. The system is working on creating a healthier environment with increased availability of nutritious options for hospital employees, patients, visitors, and other community members. Good Shepherd Food Bank, their nutritional guidelines were adopted by Feeding America, Foods to Encourage. Feeding America has taken the lead in understanding the complex and multifaceted relationship between food insecurity, nutrition, and health. Feeding America actively looks to increase the mix of healthful foods distributed throughout the nationwide network of food banks. Currently, 68% of the foods distributed are categorized as foods to encourage, which is a national framework for nutritious contributions of more healthful food categories. And as I said before, Eastern Maine, they have not adopted any guidelines yet. So here is just a picture of its checkpoint, which this is happening at Maine Medical Center. And so some of the things they've worked on are recipe reformulation, removing unhealthy items in their menus, procuring lower fat, lower sodium products in their foods, in their kitchens. So this picture is CheckPlus. So CheckPlus is a visual system. As you can see, there's a check in the middle that identifies the healthiest options in the cafeterias to make as easy as possible for consumers to make the healthy choice. And more information can be found at www.checkpluschoice.org. So there's one thing that's happening in the Portland area, Cumberland County area hospitals. This is actually a sign that is at the Good Shepherd Distribution Center, and so it's an initiative called Go Slow Whoa. And so all the foods are categorized in these arenas, and so Go is anytime foods, and so those are the healthier options. These are food groups that are found on the My Plate. And so as a food pantry comes in to purchase food, they could grab more of the green items because those are the healthy items. The food that are labeled slow, those are what they consider sometimes food. They aren't off limit, but they shouldn't be eaten every day, at most eating them several times a week. And then whoa, I apologize because it looks like there's a glare on the screen, but whoa are once in a while foods. They're the least healthy and most likely to cause weight gain and health problems, especially if a person eats them too often. So the foundation of this Go Slow Whoa is when we talk about healthy eating, it can be easy to think of certain foods as, quote, forbidden, but this is often counterproductive. Instead, with Go Slow Whoa, we use the stoplight method to teach people that there's foods that can be eaten anytime, while others can enjoy sometimes and others are for rare occasions. This message then becomes one where no food is off limits, but some are eaten best in moderation. So here's another picture of at Eastern Maine Medical Center. So this is their salad bar, which looks really inviting. And so our grant started September 30th, so we're roughly about 9 months into our grant. So we're still, I still consider us in the learning stages, but some of the ways we got buy-in from our stakeholders were to engage them, to educate them, involve all partners, so traditional and non-traditional partners, educate, develop and disseminate materials, again, educating, and then educate. So I have educate on here 3 times because I think it's very important that you educate your partners on why you're doing this work. And this, I can send this out when they send out the slides because this came out really poorly, but basically this is the baseline of the sodium content. So in the 2 hospitals in Cumberland County and the 2 hospitals in Penobscot County, we have chosen 5 food items that we will change the sodium in, and Good Shepherd Food Bank is committed to 8 items. So what this graph is depicting is the facility is over to the left, and then the name of the item of the food that's being changed, the sodium per serving and the sodium per item, and then the frequency that this is offered. So sometimes the food is being offered in the hospital cafeterias, for instance, weekly. Sometimes it's once a month. Sometimes it's one time in a 4-week cycle. So depending on how their food service is creating. Same thing with this. This is just about the baseline. So this is the 8 products. And for some reason, the bottom of this slide, which I could get this to resend when they send the slides out, but this talks about the 5 items in each of the hospitals and the amount of sodium in those items. And so obviously, like any grant, there's challenges. Some of the challenges that we've encountered are hiring at the hospital staff level. So we have the local health departments, and then a staff is to be hired at the health system level to work within the hospitals. And Maine Health has hired someone who's been on board for a few months now and who's a registered dietitian and a chef, which is really exciting. Eastern Maine is actually in the process, so it's been challenging because they haven't had somebody on board. Another challenge has been the storage of food, so sometimes it can take up more space. So for instance, some of the folks talked about how they switched to lower sodium foods, and the food actually came in like a bigger can or a bigger package, and so they actually had to figure out how they were going to store that. So that was a challenge. Adoption of the guidelines, obviously it takes lots of work and lots of buy-in. And then with Good Shepherd, the next to the working with 600 partner agencies is Good Shepherd Food Bank. So a challenge for them is that obviously working with 600 different agencies, they have different philosophies on food as it relates to hunger. And so if anyone's familiar with working with this type of population, some people have the philosophy, a calorie is a calorie, and you can just, as long as people have food, they're fine. And so that it's not necessarily having the most nutritious, it's that people are hungry and they just need to eat. So that's been challenging, as well as internal politics and philosophies. And then accepting that change is a work in progress. Recipe reformulation can take some time and be challenging. And then making sure that the food tastes good without a price increase. And so people aren't always willing to pay more for something that's healthier. Sometimes they are. So trying to still find that happy medium. And some of the lessons learned are to involve staff in the implementation decision process from the beginning, build relationships with traditional and non-traditional partners, which I discussed before, and link sodium to other nutrition strategies. So the Maine Health and Good Shepherd Food Bank that have adopted food service, adopted these guidelines, they're not just for sodium. They encompass whole grain and sugar and fat and other nutrition strategies. Do taste testing. So in the hospital to offer taste testing with patients, visitors, staff to see if it's something people would be interested. And removing healthy food and beverages from plain sight. So one of the hospitals has moved it within 5 feet of the register. So versus having cookies up at the register, maybe having fruit at the register, somebody could grab something last minute. And be prepared to think about hunger and change outside the box, especially when working with, like, say, Good Shepherd Food Bank. Change takes time. Lessons learned, the creation and implementation of a Checks Plus and the Go Slow Whoa toolkit have been really great, and we've learned that this is beneficial. Stay positive and not give up. And so some of the next steps that we are working on, again, we're in our 9th month of our first year, and then we have 1 more year of funding, is continue to analyze cafeteria menu items using the nutrition we have some nutrient analysis software, maintain relationships with key contributing partners in the leadership team, and work with partners to expand the provision of tools, training, and technical assistance to additional hospitals, provide support and education to fulfill the county gaps that we identify at the end of this year, continue to evaluate, collate, analyze sodium-related data, especially looking at some of the sales data, and continue to communicate with stakeholders, the community, on the benefits of lower sodium products and daily intake levels. That's it. So I have questions, but I think Katie said the questions will be held to the end, so I am here for any questions.
Great. Thank you so much, Holly. We really appreciate you sharing all of the work you've done and all of your successes in Maine. Yes, we will take all questions at the end of all the presentations. And I have been sharing some of the links as the speakers are presenting in the chat box. So refer to that for the website that Holly referenced, as well as the video for the Sneaky Salt campaign. So now I will introduce our next and final speaker, Misty Kruger. Misty is the Public Information Officer at Shawnee County Public Health in Kansas. After spending 3 years in nonprofit fundraising, Misty joined the Shawnee County Health Agency in 2009 as a Community Relations Specialist. She was promoted to Public Health Information Officer in 2011 and still serves in that role. Her job duties include public relations, media spokesperson, social media manager, and webmaster for the agency. She serves on the agency's management team and oversees the Gatekeepers program and the health education program. Misty has her master's in business administration from Friends University. And Misty, I will now turn it over to you.
Thank you so much. Yes, my name is Misty Kruger, and I'm with the Shawnee County Health Agency in Topeka, Kansas. And we also received a Sodium Reduction in Communities grant from the CDC. However, ours was from the first round, so our work is complete and done. And so I'm going to share some of the things that have taken place for us over the last few years that we worked on this grant. So a little bit about Shawnee County. We have a little over 175,000 people in our county. The largest city in Shawnee County is Topeka, which is also the state capital. Our grant was for $930,000, which we received over a 3-year period of time. And at that point, we were one of 5 communities to receive this grant from the CDC. We had some partners that helped along the way with this grant and took on different aspects of it, including the state health department, a community coalition called Heartland Healthy Neighborhoods that currently has over 80 members that participate in our coalition meetings. One of our community groups, Community Resources Council, and then a local communications company called E2 Communications. So our grant had several strategies that we worked on over the 3-year period. The first thing was to develop a sodium baseline for Shawnee County, and we really wanted to know how much sodium people in our community were eating and consuming. And so we worked with the state health department to conduct a survey and do diet recalls with people, and there were several steps that people had to go through to be a part of the survey, and so we did that as our first thing. And then we also looked at work site policies. I'm going to talk specifically today about the environmental support, the government procurement policies, and then a little bit about our media campaign that we worked on as well. So our environmental support was really focused on working with local convenience stores and trying to make the healthy choice the easy choice. And so we went and met with local gas stations to see if they would help offer healthier food and beverage options in their stores, knowing that we do have food deserts in Shawnee County, and we wanted to make sure that people who live in those areas still had access to healthy foods just at their normal shopping areas, which would be their gas stations. So we were able to get 13 gas stations on board with us. So Hy-Vee is a locally owned, it's actually an employee-owned station. Gas and Shop, locally owned. Larry's Shortstop is also a locally owned. And then we had Quick Shop, which that slide has a typo. I'm sorry. It says 13 locations, but there's actually 10 locations in Shawnee County of Quick Shop, and it's a corporate gas station. So we went into each of these stations and others as well and talked to the managers or the owners about being a part of this project with us. We wanted them to have signage that we would provide and work with us to promote healthy foods within their store. And we talked to them a little bit about their clientele, what kind of foods they currently were offering in the store, and kind of gauge their interest level from there to see if they would be willing to work with us. We provided some things to the gas station as well. So we came in and brought a dietitian to help go through the food that they offered. We provided all the material and marketing stuff that they would need to be a part of this project. And then we went in every month and just touched base with them to make sure everything was going okay and see if they had questions or things that they needed from us. And so when the dietitian went into each of the stores, she evaluated what they were currently selling. And what you see there is the nutritional guidelines that we use to determine if an item was a healthy option or not. We really wanted to use things they already had in their stores, so we didn't want them to have to go out and get new inventory. And actually, surprisingly, a lot of things they have met the guidelines. Obviously, a lot of things didn't, but there was enough there that we could use what they already had in the store. The one thing that we did require the stores to do was to offer at least 3 varieties of fresh fruit. So if they weren't currently offering fruit in their store, they did have to add that to their inventory. And we only had one store, one of our local stores, that wasn't doing that, so they did have to add fruit into their selection. So like I mentioned, we went in every month and did what we called spot checks. But we just made sure the displays were where they were supposed to be at the front of the store. We were really looking for point-of-sale type things. So someone may have came in to get a bag of ice, but when they were by the register, they saw the fruit, and maybe they wanted to add that onto their purchase. We wanted to make sure the stands were clean and well-maintained. All of the appropriate marketing material was visible. And then we really wanted to make sure what was on the rack was actually the items that the dietitian had identified for that store. So I went in with a checklist. To each location was different because it was based on their inventory. And so I just made sure that what was on that rack matched what the dietitian had identified for them. And then they didn't have stuff on there that shouldn't have been on there. We also tried to encourage them to keep the items well stocked, but as you can see in that picture, that didn't always happen, but they were pretty good about it. We learned you had to be flexible in this process. So we went and bought all of those cardboard stands in the beginning before we had the gas stations on board, and we learned that those really didn't work for what they needed. Some of them used them for a little bit, but as they would mop the floor and things like that, the cardboard would start to get wet, and it didn't hold up well. And so we worked within each of the stations and locations to make it work for what they had in their store. So this is a picture of our Hy-Vee station, and so we just used a rack that they already had, and we just moved the items onto that specific area. We asked the stores to provide us with 1 year prior of sales data and then track every month the sales of the items that the dietitian identified. So when I would go in to do their spot checks, the idea was to also pick up their sales data at that point in time. The local stores, most of them were manually tracking their sales, which made things a little bit difficult. And then the corporate stores, the quick shops, actually didn't come from the local stores. They came from their corporate office, which was not here in Shawnee County. So I was having to work with someone at corporate to get their sales data. This is a picture of Quick Shop. And what we ran into with Quick Shop is that they have corporate diagrams of how the store has to be set up and what should be displayed where, and they were not allowed to move them. And so we worked within those parameters and developed these little tags that had our logo, the Spot the Salt logo, which is what we used for the whole campaign, and placed them next to the price tags for those items. It worked out well. It wasn't ideal, but we wanted them on board with the project, so we did what we needed to do to get them going, and we were able to utilize that. So we, again, asked the source for 1 year prior for sales data, but as we started to evaluate the data, realized that we really actually needed 2 years prior to account for any like seasonal changes and things like that. Unfortunately, our 3 local stores were not able to do that. They just didn't have the data, and so Quick Shop was the only one who could. So we ended up with 10 of our stores being able to provide us the data that we could use to analyze. So of those 10, we had 4 of them that actually showed an increase in sales of the healthier food items from the stock list from prior to the intervention to after. All 4 of those stores happened to be in food deserts in our community, which was really important to see that. And then in doing post-interviews with the stores, we learned more about their customers, and that a lot of their customers biked or walked to the store, and a lot of them used that convenience store or gas station for their typical grocery items like milk and bread type of things, your staples. They were picking that up at the gas stations, so that was important for us to see as well. In regards to our government procurement, one of our biggest successes with this was our Topeka Zoo, and we approached them and said, hey, would you be interested in working on redoing your concession stand, and they were very much on board with it. And one of the quotes that they used a lot was how much thought that goes into the diets of the animals that are with them, but how little thought goes into the food for their guests. And so they were offering typical things that you would expect to find in a concession stand, so hot dogs, hamburgers, french fries, that type of thing. A lot of frozen items that were put into deep fryers. And so what we did with them is we worked with them to write an additional grant through our community foundation for $25,000, in which they were able to remove the freezers and the deep fryers from their kitchen, and they put in a refrigerator and convection ovens. We brought in a dietitian to work specifically with them to redo their menu and look at alternatives to items. So things like chicken strips. We worked with them to find an alternative product that would still fit within their menu but be a lower sodium option. And then there were things like hot dogs that we just couldn't find a good alternative, so the zoo was willing to just completely remove that from their menu. They did create a new menu that was called Eat Like the Animals Eat. It included a lot of fresh fruits, a lot of fresh vegetables, and things that were typical for the animals. So the bear meal, for example, offered a tuna sandwich because the bears eat fish. And so we were able to kind of tie it into the zoo and the work that they do with the animals and make it fun for the consumers as well. From that, we were able to reduce the total sodium on the menu from over 7,300 milligrams to a little over 3,000 milligrams of sodium. Like I mentioned, certain items were just completely removed from the menu because we couldn't find a healthy option. And then they also looked at price points. So they were willing to not make much on the healthy items and raise the prices of the unhealthy items on the menu and try to make their profits off of that. And then we also did some product positioning on the menu board. So we put the healthier items first and the more unhealthy items towards the bottom of the menu. And then one of the biggest things we did was a media campaign, and a lot of the money that we spent went into this media campaign. The website Spot the Salt is still up and going. It has recipe ideas, it has facts about sodium, and similar to the Heart Association website, we have this character that you see on there, Salty, and he also shows you where salt is hidden in different foods and how you can reduce the sodium that you eat in your diet. So that website is still up and going, and we hope to continue to have it up. And then the work that we did with the gas stations was actually featured as a NACCHO practice-based successes. So that just came out recently, and the web link on here will actually take you straight to that story that we did with them as well. And that is a quick and dirty of what we did for 3 years on our sodium reduction in Shawnee County.
Great. Thank you so much, Misty, for sharing all of your successes and your lessons learned with us today. So for all participants, please continue to submit your questions for any of our presenters into the chat box on your screen. Before we move to the Q&A, I'm going to share a few additional resources that can help support state and local health departments and their partners in efforts to reduce sodium or achieve the goal of Million Hearts. So the first these are our ASTHO sodium reduction and Million Hearts resources. Our sodium reduction website features case studies and resources with a specific focus on procurement strategies. And a recording of the webinar today will be available on the first URL shown on your screen. And additionally, we've gotten some questions. The slides and then the recording will be sent directly to participants as well. ASTHO is also supporting Million Hearts through a multi-state learning collaborative focused on using a framework of rapid cycle quality improvement to drive the work of states and territories towards creating systems for improved identification and treatment of hypertension. So on our website, we have an interactive map of activities and state-developed tools, as well as an online toolbox featuring resources from the collaborative, such as protocols, provider and patient education materials, referral forms, and manuals. The Million Hearts State Engagement Guide is also available from Million Hearts and on our website. In addition to what Emily shared with you in her presentation, to the Sneaky Salt campaign, AHA has scientific statements on sodium that could be a useful reference for you. From the URL shown on your screen now, you need to search the term sodium to find the statement specific to this topic. And the second resource is, again, what Emily referenced, the commentary from the journal Nutrition Today that addresses criticism of sodium reduction efforts and explains the importance of sodium reduction. And this is publicly available now online. At the end of her presentation, Misty shared NACCHO's practice-based success story about their work with the gas stations. And in addition, NACCHO also has some policy statements available on their website that can support local health departments looking to implement new food policies and organizational practices that reduce the sodium content of foods. So at this time, we will begin the Q&A session. Camelia Easley from NACCHO will moderate. And Camelia, now we'll turn it over to you.
Okay, great. Hello, everyone. We would now like to take a few questions for today's speakers. Again, feel free to enter any of your questions in the lower left of your screen, the chat box. And I have a few questions to start with. For Emily, Renee Hendrickson would like to know, is there a reason why poultry was ranked number 4 in the sodium list, and is it the way because people cook poultry, or pretty much to prepare how people prepare chicken? So is that a reason why?
So the top sources of dietary sodium intake are taken directly from a CDC analysis of data from the National Health and Nutrition Examination Survey, commonly known as NHANES, its acronym, and that was just a statistic. They looked at what people were eating in the U.S. and where the sodium was coming from, and poultry landed as number 4, and that does include both fresh poultry and things like chicken nuggets and chicken tenders. But my interpretation of why that's so high on the list is, one, because we tend to eat a lot of poultry, chicken and turkey especially, and 2, even fresh poultry that you get at the grocery store is often injected with a salt solution or some sort of broth in order to make it juicier and more tender. So a rule of thumb I always use when counseling patients is that a serving of fresh poultry should have less than 100 milligrams of sodium per serving. And a lot of the ones you see in the grocery store are in the 300 to 400 milligram range, and that's because they've had salt water injected into them.
Okay, great. Thank you. Also, Emily Terra Trujillo would like to know, what is the medical response to the new discussion around sodium being less important to control than sugar, especially if the dietary intake of sodium has remained the same for the last 50 years?
That's a good question. I'm a little bit familiar with some of the writing that a couple of academics have written on that question, and I think that they're both things that need to be addressed, and I think added sugars is certainly a key public health concern and is tied to other public health issues. So I think in my mind, it's not a question of, they're dueling issues. It's that they both need to be addressed, and I think there's impact to be seen from both of them, and depending on the population you're working with, reducing sodium could have a bigger impact than sugars or vice versa. So it's kind of hard to answer that for the general population, and I think that should really be tailored to your population of interest. But in general, I do think they're both important issues.
Okay, and one more last question. Do you have any guidelines on the acceptable content of or individual foods?
On the acceptable sodium content for individual foods?
Yes.
Was that the question? Well, I would reference the AHA's Heart Check Food Certification Program, and that program has really done a lot of analysis on what acceptable levels are, and those levels vary by food category because, for example, something like canned peaches wouldn't have as much sodium as like a canned soup. And sodium does have different roles and functions in different foods, and it's needed for things like food safety in certain foods. So there is going to be a variation in what's acceptable by food category. So the Heart Check program's values are available on heartcheckmark.org. And just for an example, I believe that for something like nuts, the limit is 140 milligrams per serving. For bread, it's 240 milligrams per serving. And for canned soup, it would be 480 milligrams per serving. So some other guidance that you could look to would be the HHS and GSA food procurement guidelines. And they've given some ranges for snacks and meals. And the FDA also has some criteria that it uses for what's considered healthy. And the reference there is for a meal or entree-sized item, like a frozen dinner, it's 600 milligrams. And for other things like serving of canned soup, it's 480. So there's a little bit of variation in some of these numbers, but I think they're all in the same ballpark and would be a good reference.
Okay, thank you. Misty, I have some questions for you. In reference to your healthier choice items, did you have any items that require refrigeration, and how did you address that issue at your gas station?
We did. All of the quick shops, for the most part, have some sort of refrigerated area, included exact things that you're talking about on there, fresh fruits, yogurts, cheese sticks. And so we did the exact same thing. They all had the price tags in the front, and so we put those little tags by their price tags, and then we put signage on the cooler itself that just matched everything else that said, spot the healthy choice, and had that little spot the salt symbol on it. But we did the exact same thing and put the marketing material next to the price tags on those items as well.
Okay. And was there any reduction in profits at the zoo from their concessions after the menu change?
I couldn't say specifically on that piece of it, but I can tell you they still have the same menu, and it's been probably 2 years since they implemented it. So, and they're still using it. So I think that they're doing okay, but I couldn't speak specifically to what their profits were or ended up being on that.
Okay. And where did the supply marketing come from for the convenience stores? Did you develop the marketing yourself, or was there a third-party supporter that already had developed materials?
All of the materials were developed as part of our grant done through E2 Communications here locally. We still have all the templates for all of that, and if someone's interested in them, we would be more than happy to share them.
Okay, great. What suggestions would you give to someone who wants to implement similar initiatives in their communities?
Was that geared to me?
I believe Holly and Misty, you guys can address this.
Well, for me, for Misty, I would say, looking for those non-traditional places that people are going, but that maybe as public health officials you don't typically work with. Prior to this grant, I don't know that we'd ever done anything with the gas stations. So just trying to find some of those key partners and finding a champion in your community that's very passionate about the work that you're doing, and trying to get them on board with it will take you much farther than where you could probably go on your own.
And this is Holly. I will ditto what Misty has said, working with traditional and non-traditional partners. So one piece that I didn't go into, and I apologize, was Hannaford. So Good Shepherd Food Bank, a non-traditional partner, well, a traditional partner, they're working with Hannaford, which is one of our largest grocers in the state. And they donate a lot of food to Good Shepherd Food Bank Distribution Center. But they have these huge food drives every year. And so working with them as they put these baskets together for the food drives to ensure that the food is lower sodium has been really beneficial. So they're going to put the cans of green beans or the corn in there for a Thanksgiving food drive, and they're just making sure there's no salt added. So it's those little type of things. But definitely looking for your non-traditional and traditional partners and your champions.
Okay, great. I believe that is all the time I have for Q&A, and for everyone's questions that I did not have a chance to address, we will have the speakers answer them and send it out with the slides and other notes from the call. And I will turn it back to you, Katie.
Great. Yeah, we're right almost at the end of the hour, so I will go ahead and wrap us up. Thank you, everyone, so much for joining us today. As I mentioned earlier, you will be immediately directed to an evaluation at the end of the webinar. Please do take a few minutes to complete that survey, as it provides us with really useful information to help us with planning our future projects. ASTHO, NACCHO, and AHA would like to thank CDC for sponsoring this event, and we'd like to say a very special thank you to our speakers, Ann Callahan, Holly Richards, and Misty Kruger. A recording of today's webinar will be available on ASTHO's Sodium Reduction website within the next few days, and we will be sending out the slides and recording and additional follow-up materials to all of today's participants. On the final slide, we have a few additional resources from CDC for Million Hearts and Sodium. If you have any follow-up questions about today's webinar, please contact me at ASTHO. My email address is shown at the bottom of your screen. Thank you again, everyone, and enjoy the rest of your day.